From theheart.org, Medscape Cardiology. This is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Professor and Chair of Medicine at Stanford University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Stanford University here on theheart.org and Medscape Cardiology. Throughout the course of the last 2 years, we've been trying to bring to our listenership, our readership, a series of topics on the intersection of COVID-19 and the heart, cardiovascular disease. So I'm really privileged today to have a colleague from the science community who's going to talk about a recent paper in Nature Medicine. But before I introduce him, let's go through a little bit of the background. I think we all remember that when we saw the early reports of the pandemic coming out of China and Italy, there was this notion that patients with cardiovascular disease, in particular, actually, interestingly, hypertension, might be at increased risk of infection and might be an increased risk of complications of COVID infection. There was also this interesting tie-in to the potential use of ACE inhibitors. Well, quickly, researchers began to understand all of these relationships and, importantly, quickly helped us understand that there was not, in fact, a relationship between ACE inhibitors and outcome that was causal in nature. So I think that was an important observation. Then we went into the summer of 2020, and we began to see these reports, particularly from the imaging community, on myocarditis. Myocarditis, particularly in young athletes, as sporting things were started and stopped, and recommendations from sports cardiologists had to be given. We've done some shows on that, including one with Manesh Patel, where we went into that in some detail. The AHA, American Heart Association COVID registry, also launched in the spring of 2020, quickly began to show, in fact, that there was an increased risk of cardiovascular outcomes in the acute phase. The AHA registry was really concentrating on the hospital phase, and so those were important. The AHA, the NIH, and others put a lot of money through rapid grant programs in trying to understand maybe some of these mechanistic links. And you started seeing papers that would continue today on this intersection of endothelial dysfunction, vascular damage, thrombosis, inflammation, all sort of tying together in patients that have been exposed to COVID-19, leading at least there to be a pathobiology that might make sense for why we're seeing this increased risk of cardiovascular disease or cardiovascular outcomes amongst our patients infected with COVID that goes beyond just pre-existing risk factors. Well, now let's take the next step, which I think is a really important one for us in the cardiovascular community to be aware of. And that is, what about in people who've survived COVID? What are their longer-term cardiovascular risks? Well, I'm really pleased to make a new friend and colleague today with Dr. Ziyad Al-Aly, who is the Chief of Clinical Epidemiology Center at the Research and Development Service of the VA St. Louis Healthcare System. Dr. Al-Aly has done some really important work, most notably a paper that appeared in Nature Medicine that I suspect many of you have read. If you've not, please take a look at it before you listen to this. That got into the long-term cardiovascular outcomes of COVID-19, as I said, recently published in Nature Medicine. So Dr. Al-Aly, thank you for joining me here on theheart.org and Medscape Cardiology.
Well, thank you for having me. Delighted to be with you and looking forward to have a wonderful conversation about heart disease and COVID.
Terrific. Thank you. First off, let's really go to the beginning. At some point in all research projects, somebody says, I've got a question or an idea that I want to explore. Do you want to start with the thinking of yourself, your broader research group, as to why you went after this problem?
So early on in the pandemic, in March of 2020, we resolved as a group is to really do our best to identify knowledge gaps that are really important to the public and address them. The conversation initially was on Zoom virtually, when everybody went home and we were all working from home. So we convened around Zoom and say, okay, we're now in the middle of a pandemic. It was around late March of 2020. And so what can we do to do our part? How can we pitch in to do our part? And it was really clear to us that although we're not virologists, we've never really researched COVID-19. We personally none of us have been through a pandemic before, but it's very clear to us that we need to sort of marshal the resources that we have and our intellect and energy to identify knowledge gaps that are important to the public and address them. And so we started doing that. And along in that journey, we started hearing reports from patients and patient-led research groups about them having, persistence of symptoms weeks and months after the initial infection. And those were initially anecdotes, in the form of an op-ed piece in New York Times. Fiona Lowenstein had a really wonderfully written op-ed piece, saying that, she was young and athletic and had no medical problems before getting COVID. She got COVID, and now, as a result of it, weeks after the initial infection, she was still having palpitation and heart problem and chest pain and shortness of breath and all of these things. And she was previously healthy and had no problems. So that really intrigued us a lot, and sort of launched us on the pathway of identifying what's happening with these people long term, what's happening with people who really survive the acute phase of COVID. And then that sort of the initial step sort of culminated in a paper in Nature in April 2021, in which that paper was really a broad characterization of what we think is a post-acute sequelae of COVID-19. What does it look like? And really the major surprising, finding there was that it really can affect nearly every organ system, including the heart. But it was not limited to the heart. There were some people with kidney problems, obviously neurocognitive, or a lot of sort of neurologic manifestations. People refer to some as brain fog, et cetera, et cetera. And so there were manifestations or sequelae or consequences in nearly every organ system. And then, so that was a revelation in April 2021 in that paper that we published in Nature. And then sort of that led us to sort of do a deeper dive into all these different organ systems that could be affected in long COVID. It could be affected, in COVID-19. And one of them obviously is the heart. I mean, we've done some other work on diabetes that would be coming out soon, and on mental health disorders and kidney and stuff like that. It sort of came out a little bit earlier, a few weeks ago. But in this paper today is really primarily focused on cardiovascular system or the heart and the vascular system.
What I really like about your explanation is, what I really like are several things. One of which is that I just love how excited you are about having had these conversations that then led you to do what you do, which is epidemiology. And so I really love the passion associated with that. The second thing is that I'm always telling the residents, the fellows, that all good research questions originate with a keen observation by clinicians, by patients, that like, well, why does this happen? Or why are we seeing this? And so I really enjoy that you had those conversations with your research group, with what you were reading in the lay press. So it's just that circle of science that somebody's got to make the initial observation and say, what is this that we should use our tools, our skills to explore? So you are an epidemiologist. You run a large research group in the VA system in St. Louis. You have access to a lot of data. The VA data set we've talked about on this show before is a fabulous national resource. So talk to me in our group about what was the design issues you were thinking about? What did you have available to you? Said, we could answer this question, or at least we could add some insights to the question. What were the methods you employed? And I had said to you off camera, we do have a lot of people who are quite experienced methodologists who will listen to this, who will be interested in why you did what you did, why you picked the methods that you did.
So first of all, I'll talk a little bit about the VA system. I do think it's a national treasure. The VA was a pioneer in adopting electronic health record systems. And the VA runs the largest integrated healthcare system in the US. There are, in a lot of states and a lot of areas or regions that are, Kaiser in northern Southern California, and there is Sutter. And so there's all these systems, but they tend to be regional, and they're not really integrated national network. And so the VA is really almost like a unique example in the US, where there is this like integrated system that admits anybody who is eligible for care at the VA, veterans, and provide outpatient care, inpatient care, rehab, et cetera. Sort of like a really broad spectrum of care from from A to Z. And because they have this electronic health record system, it makes it sort of like unique national resource or national treasure to really address questions, especially in the pandemic, an ongoing pandemic where there are hundreds and thousands of people, now millions of people infected with COVID-19, and we can sort of track them over time to really better characterize or understand their outcomes. So here the original question was, so we knew from our prior work that people, who had COVID-19, and especially people who really needed to be hospitalized or admitted to the ICU for acute COVID-19, it was not uncommon to see, heart attacks or stroke in that population, right? And that's not really novel. I mean, that should not be a surprise to anybody in the audience. So that was really, established previously. We've known that people who really got very, very sick during the acute phase, some of them ended in the ICU, can get strokes and DVT and PE. So that's really sort of comes with the territory. But what we didn't really know is really what happens in the long term. What happens when people really survive the first 30 days in the long term. And especially about in the segment of the population that didn't need hospital care, didn't need to be admitted to ICU, they didn't have a disease that was severe enough to necessitate hospitalization. And we wanted to leave no stone unturned. So we know the exposure data. We know who got COVID-19 at the VA and who didn't get COVID-19 at the VA, and then we have that data for people who were non-hospitalized, people who were hospitalized, and people who were admitted to the ICU. So we built a cohort primarily of people who got COVID-19 and compared them to two control groups. And we chose two controls here, primarily a contemporary control of people who would have the same exposure to the broader contextual characteristics of the pandemic. Those are people who were also exposed to the stress of lockdowns and all the disturbances that happened in our environment that touched nearly every aspect of our life. The school, your children, it touched almost every aspect of your life. Like people couldn't go to the gym because gyms were closed. You couldn't even go to Starbucks, right? So it was really, so we wanted a contemporary cohort, a contemporary control that were exposed to the same broader conditions. And then we wanted to validate, because also all the disruption in care, we wanted to make sure that if we find something that wasn't really, just because of all the disruption or all the, things that may have characterized the pandemic. So we also built a historical control of a solid baseline of what care looked like and heart rate conditions and disease rates, like rates of AFib, A-flutter, rates of, strokes, DVT, PE. What was it like in the VA, in the same population in 2017, in an era that preceded the pandemic? So these people were not exposed to COVID-19 before anybody knew on Earth there was even COVID-19. And then we did the analysis both ways. And so the question always, is asked without, well, people who get COVID-19 are different than people who don't get COVID-19, and how do you make it so that it's truly an apples to apples comparison? And I think the statisticians or the people who really are into methods on the podcast will know that there are a lot of methods that are available to us to really sort of balance the characteristics of the exposure group, so to speak. And we chose a primary method so like a weighting method to try to weight people in the cohort so they have actually the same characteristics, demographic and non-demographic in terms of health characteristics at baseline, to kind of even the playing field, so that the only difference between the COVID group and the control, or control 1 or control 2, is the fact that the COVID group got COVID-19. That's really should be the only difference theoretically. And then ran the analyses to look at a pre-specified set of outcomes. And some people ask, like, well, why did you select these outcomes? Why not something else? Our outcomes were primarily selected based on the prior work, like the paper we did previously on a broader characterization of the post-acute sequelae of COVID-19, and the literature that we had at the time, like that suggested that, some, COVID-19 might increase the risk of myocarditis. Some people might have pericarditis. We knew also like the DVT, we knew the PE story, we knew the stroke story. So those are all sort of bits and pieces from much smaller studies that we put them all together. We sort of leverage all that information that was available to us at the time to say, okay, well, let's examine the risk of or the association between COVID-19 and all these outcomes one year out. And that's sort of the broad outlines of what we did. And
I'd ask people to read the paper and look at the methods, because you also, I thought, did some clever sensitivity analyses to make sure that in fact your weighting was the appropriate method. You looked at some other methods. You did some work looking at people exposed to flu. So again, for the methodologists on the call, please look into it. I think this is elegant work. Well, describe the primary outcomes and your key findings, which I thought were not just interesting, but extremely consistent.
So the main finding was that COVID-19, even a year out, people with COVID-19 have higher risk of stroke, cerebrovascular disease, including strokes and TIA. There's actually a bunch of arrhythmias or dysarrhythmias, including AFib, and some people actually had tachycardia, and some people have bradycardia. Well, the cardiologists on the call that probably won't be surprised, but it was a bit surprising to us that there would be that sort of this sort of the diversity of outcomes, and there were signals related to myocarditis and pericarditis, or I should say increased risk of myocarditis and pericarditis. There was also increased risk of heart failure, which was to us is also interesting, and increased risk of thrombotic or thromboembolic disease, including pulmonary deep vein thrombosis and pulmonary embolism.
Yeah, and I thought the figures are beautiful. There's figures in the main paper, there's figures in the supplements, and people should take a look at it. One of the striking things to me was just how consistent the message was across all these different diseases. Talk a little bit about these data obviously have limitations. These data obviously have some important strengths to them. The nationwide survey, the diversity of the patient population, but it's also mainly a male, mainly a white male, veterans population. So talk a little bit about the limitations that you see, just in the spirit of full disclosure.
Sure, absolutely. So like any work, any scientific work, it's always there's actually quite a bit of limitations here. First of all, as you described, this is within the VA system, so it may or may not generalize to people outside the VA system, because in the VA system, people have sort of different behavioral characteristics or different differences between sort of the VA and the general population in the way the VA, the VA population itself, or the way the VA provide care, et cetera, et cetera, et cetera. So that's really needs to be sort of taken into account. And two, really the demographics of the VA population, as you noted, are older, white, and males, and that's really important. But it also important to sort of put it in perspective that so people tell me well, most of your guys were white, but I also counted that 20% of our people are Black, participants, and because of the study is big, it's about 154,000 people with COVID-19 and nearly 11 million controls. 20% is 2 million people. 2 million people is not a small number of Black people in our study. And they say, well, most of veterans are males. It's true, but 10% of our VA population nowadays is females, and 10% out of 11 million, that's 1 million female veteran. And so even if we take this 1 million and do a sub-study on them, it would still be the largest study to date on cardiovascular outcomes in female veterans. So I think need to be sort of taken into consideration that this is really a large study. The third thing that I think is an important limitation is that, however we try to do the weighting and controlling for confounding and try to even the playing field, I think we have to all be cognizant that there might always be, we cannot fully eliminate the possibility that there may be confounding out there that is unknown or unmeasured to us, or either unmeasured or unknown to us, that we couldn't account for. Now, the testing the negative control really worked. It did. Doing the negative exposure control, it did. That reduces, but does not eliminate concern about confounding. So I think we have to be objective about it. Does it lessen the probability of confounding? It lessens it, doesn't eliminate it, doesn't make it zero. And I think people need to sort of understand that. But also the counter argument to it is that it wouldn't be feasible for us to randomize people to COVID or no COVID, right? So that's really when I tell people observational work and causal inference isn't really going to add to our understanding. Well, the counter argument to it is probably the only thing that's going to add to our understanding here. because it wouldn't be feasible for us to actually randomize people to, oh, we're going to give you COVID and we're going to give you placebo, so no COVID, and then run you for a year or two and see what happens to your heart. We're not going to do that, obviously. So I think the better approach is to how can we work more intensively and rigorously on the science to really elevate confidence in the work or elevate confidence in the rigor of the approach, and also understand the limitations. So when we interpret the evidence, we interpret the strength and also the limitation in each study, including ours.
Yeah, I mean, I like to say that you should choose the right research methods for the question that is at hand. And in this particular case, the observational data is what we have to look at this particular question. And I thought you were very careful in both your the number of analyses that you did, including sensitivity analyses. And I thought you were also very careful in how you presented your results, and you were the same way today. As we get to the end here, I'm going to ask you quickly to give me the implications. I'm a cardiologist. What should I be thinking about with these data? What should my patients be thinking about with these data? And for someone like you who advises policymakers, et cetera, what should the policymakers be thinking?
So for cardiologists, I think we need to start thinking, at least, it's still in the hypothetical realm, but we need to start thinking about COVID-19 as potentially a cardiovascular risk factor. And how does it really compare or stack up vis-a-vis, hyperlipidemia or hypertension or diabetes? I don't know that, but I think we all as a community of scientists and physicians need to sort of start thinking about it. Like now, whether we know it increases risk, how does it really stack up against other things? And two, when we're evaluating patients in clinic, to really keep that knowledge in mind, that we really ask people about whether they're actually indeed having chest pain or not, having palpitation or not, new swelling in the legs, shortness of breath, manifestations that could actually be symptoms of a much larger problem that, if detected early, always leads to better outcome than leaving it to the end. And for the patient community, I think also things we didn't touch upon is that risk overall is only important because there are so many people with COVID-19, but the relative risk, or actually, if you look at the outcome of MACE, which is really arguably the most consequential outcome, it's like really, it's not just minor or chest pain, it's MACE, it's a major outcome, right? So on the absolute scale is 4%. And that means 96 out of 100 will just do fine, right? Will have no problem. 4%, meaning 96 will do fine. So it's certainly not cause for panic, certainly not cause for people to really lose sleep over it. But I think it's important enough because multiply 4% by the larger number of people who got COVID-19 in the US and globally, and you end up with a potentially a trend that fuels a surge in the burden of non-communicable diseases more broadly, and specifically in cardiovascular disease in the US. So certainly it might contribute to it, but I think it needs to be taken into consideration, not sort of not muted or disregarded as like so too small, and also not exaggerated. I think it needs to be sort of a contextualized for what it is. But going back to my advice to patients is that really to take things seriously. If they're having problems with their heart or chest pain, definitely seek help earlier than later, because we know that COVID-19 leads to potentially long-term consequences of the heart, and identifying those earlier than later is absolutely the right approach. For policymakers, I think the broader thinking is that we all thought that SARS-CoV-2 or COVID-19 is really a respiratory illness that that can involve the respiratory system and it goes away in a 1 week or 2 weeks or 3 weeks. We thought everybody was thinking like that in March 2020. It is clearly evident, as really clear as the sun, that it is not that COVID-19 or SARS-CoV-2 is really more like a systemic virus that can, in some people, not in everybody, in some people, leave its marks on extrapulmonary systems. And just because of the huge number of people infected with COVID-19, even things like 4% will translate into millions of new people hitting the clinics with cardiovascular disease. And I worry that as a nation, and actually as a world, we are not prepared for this. I mean, keep sort of repeating the same thing. We collectively, without assigning blame to anybody, but we collectively dropped the ball on COVID. I feel like we could have done better with COVID, and we didn't. And then I sort of feel that long COVID is really a complex problem, and we're really not prepared to deal with it. I don't really feel that there is enough conversations, nationally, internationally, in different governments and WHO about long COVID. I mean, those conversations are not totally muted, but they're not as vibrant and as really, front and center as they really should be. And I worry that now the sort of the conversation around moving on from a pandemic to an endemic stage, lifting mask mandates, and while totally ignoring that this virus in some people it could leave them with sort of literally scars that will mark them for a lifetime is in my view is certainly not the best calibrated approach. So I'd urge people to really consider the long-term consequences, or policymakers to consider the long-term consequences of COVID-19 in policy discussions and in public health or decisions that affect public health. And that's very, very, very important. And planning for the future, or planning for the after effects of the pandemic, is going to be quite important. And people are going to be flooding our clinics. I mean, that's really, we already see this. I don't know. We already see this, and it's playing in slow-mo now, but soon enough, it's going to be quite staggering. And our health systems are already strained after 2 years of dealing with COVID-19. I think we're all exhausted and strained, and we certainly need a more concerted effort to help us all sort of be able to deal with the challenge of long COVID.
You said that, you summarized that, I thought, really beautifully. And as you point out, while 4% absolute in cardiovascular disease, I'm used to dealing with 1 to 5% absolute risk differences, because that's where we play in terms of the risk of myocardial infarction. A new therapy might lower that risk by 1-2%, and so 4% for us as cardiologists is real. Particularly, as you've said, given the magnitude of what we're talking about, and we're talking about millions of people exposed. 4% is a big deal. So thank you for summarizing it like that. Well, Dr. Al-Aly, I could talk with you all afternoon. This has been fabulous. I want to thank you for, number one, doing what you do, which is contributing to our scientific knowledge of the long-term effects of COVID. So keep it up. Secondly, I want to thank you for coming on and really diving into what I think is a pretty important paper for our readership to take note of. And I want to thank you for going through it. I also want to thank you for the honesty and the clarity of what you did and what's good about what you did and where maybe some of the limitations are. I applaud that as a fellow researcher. So thank you again. Here on theheart.org Medscape Cardiology, it's been my pleasure to talk with Dr. Ziyad Al-Aly, who is the Chief of Clinical Epidemiology Center at the VA St. Louis Healthcare System. And I'm Bob Harrington from Stanford University. Thanks for joining us.